You're welcome to my channel. Today I'll be talking about Reiter'S Syndrome. Reiter'S Syndrome is also known as reactive arthritis or sexually acquired reactive arthritis. Either you call it reactive arthritis or Reiter'S Syndrome, it is secondary to an infection. Might be during an ongoing infection or soon after treatment or resolution of the same. Confusion occurred in the past before certain organisms were identified. You can have joint aspirate that may not yield specific organism. There's a triad that we'll be looking out for to make the diagnosis of Reiter's syndrome. That will be conjunctivitis with urethritis and arthritis. Epidemiologically, Reiter's syndrome is rare, but when it is found at all, it's going to be in young adults. Men to women ratio is equal, and it is a variant of spondyloarthritis. What are the clinical features? It's going to be acute in onset with asymmetrical joint pains, oligo or polyarthritis, meaning might be affecting only one joint or sometimes more than one. But specifically, we'll be dealing with extra articular symptoms. That will be pathognomonic here. So I'll quickly go over the articular symptoms, then go over the extra articular symptoms later on. So when you have acute arthritis in a young adult, the arthritis will resolve within 6 months. Chronic arthritis will set in, and that will last longer than 6 months. There will be joint pains affecting the lower limbs, for example, the knees. It might be one joint, but like I said just a few minutes ago, that it might be poly. Upper limbs are not spared, but lower limbs will be affected more. Still on articular symptoms, the small joints could be affected, many of them forming polyarthritis of the small joints. Then we have an entity known as enteropathy. That is when there is inflamed site of insertion of the ligaments, tendon, joint capsule, fascia, or bone. Then that could occur right here. That arthritis will be found in 40% of those due to chlamydia. There might be low back pain that is affecting the axial structure. Okay, and then pelvic joint could also present with pain. Now, extra articular symptoms. You can now see that you have both articular and extra articular symptoms. Conjunctivitis, that's one of the triad, right? Anterior uveitis, episcleritis, keratitis, dysuria. Urethritis, one of the triad, right? Cervicitis. Still on extra articular symptoms, the young adult could present with diarrhea, oral sores, the sole with keratoderma blemerohagicum, psoriatic nail changes, or balanitis. Other extra-articular symptoms will include valvular heart disease, aortic insufficiency, or pericarditis. You can see why it is so important to really make the diagnosis and treat properly. Pelvic inflammatory disease, prostatitis, or cystitis. What are the sources of infection leading to Reiter's syndrome? gastrointestinal tract, urinary tract, or sexually transmitted infections. And sometimes could be aseptic. How do we make diagnosis here? We can make diagnosis here by taking thorough history and full physical examination. There will be a lot of investigations to be done. I'll go through them in a bit. You may not identify a specific agent in almost half of the cases, meaning in 50% of the cases, you will not make specific diagnosis. Now, there's arthrocentesis, that is joint drainage or joint aspiration. And what are we looking for? We're looking for crystals, gram staining. We do polymerase chain reaction, that is enzyme-linked immunosorbent assay or nucleic acid amplification test. I'll tell you in a bit what we want to gain by that. Still on diagnosis, can have stool microscopy culture and sensitivity tests, the same urine MCS, eye vaginal swab MCS, like I've said, nucleic acid application test. Complete blood count will be pointing to neutrophilia, urinalysis, and cell diversity antigen, simply known as CDAV. You can still continue while you are trying to code down on specific causation here by having erythrocyte segmentation rate, see reactive protein, rheumatoid factor. Then you screen for the HLA when genetic factor is in question, and HLA B27 will be needed here. Anticyclic citrullinated peptide antibody. Here you are ruling out autoimmune conditions. Still on diagnosis, you want to know how much damage has been caused to that joint, so you can have X-ray done or CT scan, magnetic resonance imaging, and because of the probability of heart valve involvement and pericarditis and everything, you can have EKG done. Now, remember, part of the triad is conjunctivitis, so refer to ophthalmologists for full screening. But right there at the clinic, you can just have ophthalmoscopy done. Now, the differential diagnosis, meaning if it's not Reiter'S syndrome, what else could it be? It might be septic arthritis, it might be gout. There's a full presentation on gout already published by me. You can check my channel for that. That's why we're looking for crystals from the joint aspirate the other time. Then it might be rheumatoid arthritis. That's why I listed some investigation that could be done while ruling out autoimmune condition. Might be Lyme disease. You can check my channel for full presentation on Lyme disease right here. And then it might be inflammatory bowel disease. Check my channel for full presentation on that as well. And it might be celiac disease. Could be gonorrhea or chlamydia infection, which is a culprit here anyway. Could be as a result of BCG given in someone with bladder CA. Could be spondyloarthropathy or post-streptococcal reactive arthritis. How do we treat? Yeah, we have to treat the underlying condition. Of course, if you don't get to the root, you keep coming back. Antibiotic coverage should be based on the microscopic culture and sensitivity results so that you don't waste the time and money. But if the individual is under acute trouble, severe pain, nausea, vomiting, diarrhea, then you can go for empirical antibiotics until the result of MCS is out. Then you give specific antibiotics that the agent is susceptible to. So you can choose from topical antibiotics if there's open wound somewhere. We can go for rifampin, zithromas, doxycycline, but don't give doxycycline in anyone that is pregnant or anyone less than 8, and some will say less than 10 years. So just don't give doxycycline to children that will be less than 8 or 10 years, and not in pregnant women. Vancomycin and cephalosporins. Still on treatment, depending on the presentation, you may make use of non-steroidal anti-inflammatory drugs, can make use of topical analgesics, or glucocorticoids intra-articular or systemic, or disease-modified anti-rheumatic drugs, might be tumor necrosis factor inhibitor, methotrexate, or you refer to ophthalmologist. Now, prognosis. It's going to last between 3 to 6 months, but that depends on the underlying pathology. The affected individual may then come down with chronic spondyloarthropathy after you must have finished your treatment. So with that, I come to the end of this very short presentation as per Reiter'S Syndrome. Check out for the triad. Thorough history, have your suspicion, go to the lab, get everything done, but in 50% of the affected people, you may not get anything from the laboratory investigation. So don't be disappointed. High index of suspicion. Thanks for listening. Remember to subscribe to my channel. Remember to share this presentation. I appreciate it.